Hey everybody, my name is Mario Martinez, and this is either amateur EMS or amateur medicine. I don't know if I've changed it already yet. Right now it's EMS, but I think I'm going to change it soon. So good to see you guys. So a lot of people have been asking me non-stop, and you can see it. Fast forward, I did one to myself, for an IV tutorial guide. And so I'm going to try to do that today for you guys and kind of show you my thought process on everything. I did this before I did this part, so it's going to be kind of, it almost will seem a little bit out of order, but I promise you it'll be smooth whenever we start. So, we're going to jump right into it. The first thing, always wear gloves. Always wear gloves. If you don't wear gloves while you're starting an IV, you are disgusting. And you were taught incorrectly. And I feel bad for you, honestly. A lot of times, especially more so you see hospital staff will do it, they will set up an IV on a patient, right? And then they'll work on palpating for an IV. And this is called an amateur channel. They're even worse, right? And then they're feeling for an IV, right? And they're like, I can't feel it yet, right? Or they're feeling for an IV. And they're feeling for it, and they're like, I can't feel it. And then they pop off their finger. Oh, that actually hurt. I don't usually do this. And they're like, I need to use my finger. Okay? I need to use my finger on this one. Trust me, it's going to help me feel it out better. And they're like, oh, now I can feel it just fine. No, this is for noobs, okay? If you were taught this way, you were taught with a crutch, and you should be embarrassed if you have to do this, okay? It's disgusting, guys, and it really needs to stop. So if you learn from me, you'll learn that this is not an acceptable method for feeling for an IV, okay? We're not touching our patients, okay? If that happens, just wear tighter gloves. For the longest time, I thought it was a large in gloves. Now I figured out I'm a medium in gloves. Okay. All right. So I'm going to swap my glove. That's just how easy it is. Sometimes you may need to dry your hand a little bit, right? Some people like to blow on the glove. Like, what does that even really do? But it might take me a second to put it on. I just had another pair of gloves on. Okay, I've got my gloves on, so let's get that out of the way. We don't do this whole ripping the fingertip thing. Nonsense. Second one, when we're looking at a person's arms, first off, we need to ask, have they had cancer in the past? Or are they on dialysis? Is there a reason why, let's say, this arm is restricted? If this is restricted in any way, if they've had breast cancer in the past, any type of cancer referring to this arm, or any type of surgeries, or if they have a fistula, a little bump, which they use as a port for dialysis, we do not use the arm that we're considering, okay? We'll use the other arm, all right? And if we need to, if we can't find an IV here, we might need to consider IO, depending on if they're hemodynamically stable or not. If you have a paramedic, they'll know it's where you drill into somebody's arm, or not to their arm, into their bones, instead of starting an IV. And they have different axes, right? So they'll think of the humeral head, or they'll think of the tibial tuberosity. They're considering an intraosseous infusion. So we have a couple of things here, right? We have our IV start kit. Let's take a look at what our IV start kit has, and each one's going to be a little bit different. So we have our gauze pad. This is for whenever you mess up, so we don't open that. It's nonsense. We have our techoderm here, and we can peel this open. And the techoderm is what we use to make a seal for our IV port, okay? So we'll peel this off like so. And then you can barely see it here, but there is a little slit down here that we use to wrap around the IV port. So we have that there. Sometimes some people, what they'll like to do is they'll peel it back a little bit. They'll set it up like so. It's fine. However you want to do it. We have our alcohol prep pad. This one has two, which is fantastic. It's very nice. Sometimes what I like to do is I'll take my alcohol prep pad, put it on top of here, and just leave it here ready to go. Iodine, it's here to trick you whenever it's 2 or 3 in the morning. We really don't use the iodine for anything, at least IV-wise. This is only here to trick you, okay? I'm sure there is a reason why emergency department staff would like this. For us, garbage, right? Why is it in here? This little tag, garbage. We don't need that. I'll clean that up later. Band-Aid, we have this here to trick people, right? We don't need a Band-Aid for this. We use gauze pad and some tape. So this, garbage. Why is it in here? Tape is very important. We can use it to help secure our J-loop more. Sometimes we can use it to secure our IV port a little bit more. There's actually a little cool couple things that we can do here with it. But for now, I like to leave it a little unpeeled, and I'll set it up like so. And here we have our tourniquet. So we'll take our tourniquet, we'll pop it out, and while I'm setting up with everything else, it's a great idea to go ahead and put a tourniquet on your patient's arm, okay? And I need to get a mannequin arm, and I'll simulate all of that. But while you're setting up with everything, let that blood kind of build up a little bit, right? So we'll put a tourniquet on him. One special thing to note, if you have a geriatric patient, you want to put the tourniquet on the sleeve instead. That's because they have thin skin, because they have a lack of adipose tissue as you get older. So putting a tourniquet on something like right about here is generally ideal, because it still does the same thing, but it puts less pressure on the skin. It doesn't tear as easily, so we're really happy about that. Another thing, we like to go for the hands, then we like to go for the forearms, then we like to go for the AC veins. Okay, we like to go for these. Some people will swear that it's a good idea, like, oh, if I can't find an IV on their arm, I'll do an IV on their foot, right? No, it's too far away from the heart. If you're in an ER or an emergency department staff and you have certain protocols, okay, I guess it's fine, I guess. But you know what the foot is? It's very dirty. Okay, it's trapped in socks, sometimes shoes. For me, it's steel-toed boots. It gathers bacteria and fungi the whole time. Steel-toed boots are commonly, they don't breathe well. So you could develop things like trench foot if you get a little wet. It's just a bacteria and fungal-ridden environment. And so we don't want to start IVs there, especially if they're diabetic. We have a great chance of causing an infection, and that's the last thing we want to do for our patient. Okay, so we have our tourniquet here. We would normally place that on right away. In fact, I'm probably going to simulate that right now. So, luckily I'm at my training station, and I have a perfectly simulated arm right here. As you can see, we have some pretty decent spot for IVs, and you can see he's been poked a lot. But you can kind of already visualize some in the hand. You can visualize one right by the radius, so right about here with the thumb. It's my personal favorite one to go for. We also have a pretty decent spot for IVs for the AC. Little trick, if you are a student and you're kind of worried, oh man, I have to start IVs in front of my preceptor. If they give you a dummy arm, take a look at the dummy arm. We can look here and we can see all these different past marks where students have stabbed into it. Okay, so if you're worried as a student and you have to do IVs in front of your teacher or your instructor and they're kind of a little bit tough on you, then just say, where am I going to start this IV at? You see 20 marks on a fake arm. You say, I guess I'm going to start right here. And they'll be like, that's good, he knows his stuff. That was a good choice, right? Don't just try to pick a whole new landmarker like over here, even though you may want to consider it. Just pick the obvious spots. Another thing, if you're actually starting an IV on a patient, go ahead and ask them, hey, where do they normally get IVs at you at? Oh, they normally get it right here. And then normally that's the best spot to get an IV for a patient. So it's a good idea to always ask. We want to go for the hand first, then the forearm, then the AC. But a lot of times whenever people get more experience, they just go straight for the AC. I mean, I think it's fine, but it's up to you and whoever is instructing you. So I would take my dummy arm here, and I would take my tourniquet, and I'm going to wrap it like so. And you can see I have the two ends right here. I'm trying to visualize it as good as I can. I'm going to tighten it up, and then I'm going to pop this one underneath like so, and tuck it in just a little bit. And I'll normally leave it like this. So if I need to, I can just grab this end here and pop off the tourniquet later, and then I'm fine. Okay, so I'll readjust that and put it on like so. So I'll tighten it up. And then I will lock it into place here. Leave it like so. Whenever I need to, I just grab this end, pop it out, and I'm done. Okay. The next thing, if this is my patient's arms, and you can't really visualize it too well from my angle. So like, let's say if my patient is sitting down right here, right? And I am in the ER, or I'm in the back of my medic unit. And again, I wish you guys could visualize it better. My patient's arm is right here. I'm taking that arm, okay? And I'm holding on to it, and sometimes they'll kind of lean more towards bringing it back to them. Nope. This is my arm. For the next 2 minutes or 3 minutes or so, this is my arm. And I'm taking complete control of it, and they start moving away. No, I need to use your arm. okay? But at the same time, know your abilities, okay? If, let's say I'm going for an IV and I'm going for right here, right? Okay, know if you're good at applying pressure and stopping the venous return, right? Know if you're gonna cause any blood to come out of your IV catheter. And if that's the case, okay, be ready to move your leg when the time comes after you pull off your tourniquet and you're setting up your saline lock, because you don't want blood to go down and hit your leg or your shoes, which a lot of students have issues with. So, take control of your arm. Put your tourniquet on. Some people, I consider this to be a mistake. Others will tell you differently. They'll see a vein right here. It's as obvious as can be. And they'll be like, well, let me feel for it. And they'll be like, oh, well, I feel a good one here. And then they'll go for this. In my opinion, if you see it, it's usually there. Now, there are really thin ones for geriatric patients that may look visible but aren't really the best spots. But for the most part, if you see it, I mean, the vein is literally right there. So use your eyes a lot. A lot of people will say use your finger, but I mean, it's good to feel it as well, but it's okay if you see it. I mean, technically it's there, right? It's literally visibly there. Some will roll on you or blow out on you. If they roll on you, it's because you weren't putting enough traction here. And they'll say, oh no, trust me, this patient's IV, or this patient's veins, they rolled on me. More than likely, they weren't putting the proper type of traction, or something was just going wrong. Like, some veins can roll a little bit, but I would say 95% of the time, let's use your error. And I make mistakes a lot too. But I kind of hate it whenever people say that and use that as an excuse instead of just admitting like, oh, I messed up, right? They'll say everything except for that. It is what it is. I don't like going for the veins here. I'll go for here though, and I'll go for here as well, right? This is kind of what I imagine is my arms, or the area that I can work in. I won't go for these veins. I kind of find that this is like an area that I don't disturb personally. Other people may teach you differently. So, I have my tourniquet on. This guy's arm is mine. I'm going to take my alcohol prep pad, and if I'm going to go, let's say I want to go right here, okay? I'm not just going to do a little circle, or if you can visualize here, I'm not going to do a little circle. I'm going to do a big circle, okay? If I need to move around, or if I forget exactly where I cleaned up, this gives me a lot of wiggle room, and it also helps clean up my patient. I can look at this, and I can say, this is a little dirty. And if that's the case, what's to stop you from cleaning a little bit more, right? We want to protect our patients from infection. If you feel like you are justified in pulling out a second alcohol prep pad, pull out a second one, okay? Just clean around the general area. Get a nice big circle. At hospitals, they'll have this thing that like clicks and they can rub against it. What's really great is if you rub against it a lot, sometimes a vein even pops out a little bit more. It's a great tool to have. So you have your patient's arm. This gauze pad should not be opened up, okay? This is what losers open up. That mess up and they know they're gonna mess up. This is for if you make a mistake. We do not set up to mess up, or we do not set up for failure. We don't open this. We open it if we mess up. Okay? We will take our saline flush right here. This one opens like so. And generally all saline flushes are gonna be about 10 cc's of saline solution, okay? Next thing we're gonna do is we're gonna take either our saline lock, and I'll show you what it looks like. It's this little hub right here. The purpose of this is if I were to set this up on an IV, what's to stop the blood from returning from the IV back into the saline flush and then out, right? The thing that'll stop it is either the saline lock or a J-loop, which I'll also visualize for you guys. So we'll hook up the saline flush like so, and be mindful where you place these things at after you're done. And what I like to do is I will leave the lock or the cap on, and I'll push a little bit and it'll kind of give me a little bit of resistance, but it'll fill up this void space. I like to leave the cap on just because I like to leave things in a sterile environment. Some people do it differently. That's okay. Whenever it's time to use this though, watch this. Without trying to touch that, right? You can just push it off and then use your flush accordingly. But I'm done with this. Here is the J-loop, the other one. Okay, so here's the J-loop. It's the exact same thing, except there's a little bit extra line. So I'm gonna pop it in like so. And as you can see, there's some air that's from this part of the tubing to here. What I'm gonna do is I'm gonna push my saline flush a little bit. I'm gonna advance my saline. I'm gonna let it pour out a tiny bit. just like so. And I filled it up with saline fluid from my flush. However, if for whatever reason there's like 1 or 2 mini air bubbles, it's fine. 60 cc's of air is supposed to be the time whenever you start to see any danger with your patients. It doesn't mean that we don't want to clean out these lines, but if there's like 1 or 2 air bubbles, don't stop everything and work on it. It should be fine, okay guys? But it's good for you to pay attention to that, especially whenever you're starting off. So I have my J-loop here. I leave the cap on because, again, I like to leave it to where I can pop it off and I don't have to worry about keeping it sterile at that point. I have my Techoderm already set up. I have my tape set up. Now you'll have a choice here, okay? 22 gauge doesn't even count. Only time you consider 22 or 24 gauge is whenever you're dealing with a pediatric patient. I can even show you like what a 22 looks like. This is a 22 gauge, okay? Don't let me catch you using this on the box for an adult patient. Doesn't exist. The lowest that we'll do is a 20 gauge, okay? Which is like so. And then we have an 18 gauge. If you're riding out on the box with me, if you're a new individual, this keeps on popping up, I mean, it's fine. Then for the first couple months, you're only allowed to use this unless I have special considerations for a patient like they're like, I only can do the hand and I can only barely do it, and da-da-da. There's a couple different reasons. I'll consider letting you use a 20 gauge, but we need to get out of the habit of using 20 gauges, guys. An 18 gauge is just about the exact same size. I'm going to pull out both of them to let you visualize it. Don't worry, this guy's fine. Tourniquets don't even hurt an individual till about 4 or 6 hours of leaving it on straight. From some studies that I've read recently, we're going to open up both of these just so you can visualize it. So don't worry about it, okay? I'm going to pop out both of these just so you can look at the difference. Come on, you. It's really hard. And here are the 2 different needles. If I can get it out of focus and into these needles. Now the green one, you could argue is a tiny bit thicker or a tiny bit bigger, but not by much, guys. Not by much. I mean, we can kind of see that the green one is a little bit thicker. But again, guys, be very careful. By the way, these are sharps. These are sharp tools. Be very careful with them. Don't worry about it, guys. There's like almost no difference at all. And sometimes people will psych themselves out and they'll never move from 20 gauges to 18 gauges because they'll be too concerned about like, oh, well, what if it's too big for the vein? Just use the 20 gauge, okay? The ER staff will love you if you get a 20 or an 18 gauge. Flows a lot better. If you get the 20 gauge, they're like, thanks for the IV. It is what it is, even though there's really not much difference. I'm also going to go ahead and show you while you're here a recap method. We never, for instance, recap like so. This is incredibly dangerous to put a cap on like so. I'm only visualizing it. Do not do this. Do not do this. Okay? Instead, leave container for the sharp on a table and then ride it alongside like so. And then from there, I can pop it back into place if I need to. Okay? Same with the 20 gauge. Okay, I have a 20 gauge. I have my cap right here. Just gonna ride it alongside. And you should never have to recap anyway. But it's on like so. Snap it into place if I needed to. That's fine. Well, now this thing that I'm going to visualize for you guys. So, we have our IV catheter and all of its glory. In fact, I'm actually going to show you this in the classroom setting, so don't worry about it. I'll show you guys what it's going to be like simulated with me starting an IV. I need to put this cap back on because I'll do this in the classroom. So hopefully I will have broken up this video properly to have gone over this with you guys. But I have my patient's arm. Sir, this is my arm, sir. Do not move it. Again, I have my alcohol prep pad. I'll decide, I want to do it right here. I'll clean up around this general area. And I'm going to break my lock. So I'm going to twist it left and right. I'm not going to go up and down with it because I don't want plastic to get in. I'm going to take his arm. I want to pull traction like so. I don't want to be too close because if I do too close, then I am potentially messing up with my downward angle. I'm going to pull traction like so. I have my IV my IV catheter. I'm going to go in like so. Okay, come on. Okay, I'm in. I see flash, or I see some fluid start to build up. Then I'm going to advance my tourniquet like so. And then afterwards, I'm good. Now, I didn't really describe it too well here, But if you get flash from a patient, or if you stick a patient and you start to see fluid buildup, advance your catheter just a tiny bit further. And I'll show this either earlier or later on in this video. It's because if you look, there's plastic on your catheter, and then there's your needle. A lot of times people will get flash, but then they'll advance it, or they'll undo everything, and they'll be like, hey, my IV's still no good. It's probably because you got the catheter, or you got the needle in, but you didn't get your catheter in place, okay? So we need to advance a little bit further to get that catheter inside the vein, all right? So now that I'm finished, it's wiggling around. This is not a big deal. Do you guys see this popping out? And I probably have already shown you with myself, but do you see this catheter coming out? No. It's in place. Is it shooting out blood? No. No, it's not. Why not? Because I still have my tourniquet in place, and it's still locked in, basically. So I have my J-loop ready. I'm giving myself some time to worry about. This is where I pop the tourniquet. Tourniquet is popped. And then I'm going to, again, control his arm. This is where a lot of students mess up as well. They will not apply appropriate pressure to hold the catheter in place. And so what I like to do is I like to apply pressure here, and I'll apply strong pressure. And then I'll put my last two fingers here. At the same time, I will take my index and my thumb, and I will place them on the sides of the catheter. I don't know how to visualize that too well. But that way I can hold it in place. All right. So I'm pressing against it. And then I'm going to undo my catheter, my sharp. I'm going to toss it in the sharps, and I'm going to go ahead and I'm going to put in this flush. So I'm putting appropriate pressure. Don't be too nice with this. This is why you end up getting blood coming out of the catheter. It's because you're not applying enough pressure. You need to apply pressure like you're mean to your patient, okay? And if you're having issues with blood coming back out before you set up your saline flush, I highly recommend you practice applying a mean amount of pressure. So apply pressure, apply a good amount of pressure. The same with your two fingers back here at the very end, apply pressure, okay? Grab onto it. It's even sticking out a little bit. That's how much pressure I'm putting in. And I'm gonna take it, I'm gonna slip this off. I'm gonna keep it to the side, but I'm gonna know, hey, my sharp's right there. Everyone watch out, there's a sharp. This J-loop, I don't really use J-loops too much. Pop that off. I'm going to establish it like so. I'm going to pull back a little bit. I got some blood return, great. For this arm, I can't really visualize it. I'm gonna push. I don't even know where the saline's gonna go. Anyway, you're gonna push your whole 10 cc's of fluid. We'll just say that I did. Then I'm gonna DC it like so. I'm gonna take my tourniquet, or my techoderm, and there's gonna be this little slit right here that I talked about earlier. I'm gonna take it, I'm gonna unpeel it, and I'm gonna place it like so. And then I'm gonna remove the plastic off of the area. So more so, this is kind of what you're looking for with your J-loop. Be very careful with this, by the way. You don't want this rubbing against pants or anything like it is for me, because you don't want to cross-contaminate anything. Then from there, since I have a J-loop set up, what I like to do is I'll take some extra tape. I can secure it a little bit extra like so, just so that way it doesn't dangle and get in my way or patient's way. If you have the saline lock, then you don't need to worry about this part as much. But I'll secure it like so. If I'm worried about, hey, is the catheter going to come out? Then okay, I can even put some more tape right over my techoderm, like so. And you might notice a little bit of blood return coming from your J-loop. If that's the case, go ahead and lock it like so. I actually need to put a little bit more tape here. Oops, sorry sir. More or less, we have it set up like so. We have our techoderm on. It's not on too well, but I have some extra tape just in case, and I also put some more tape securing the J-loop, especially whenever we're transporting, okay? Huge gripe that I have. This is my sharp, by the way, goes in a sharp container. Make sure you knock that out right away. Huge gripe that I have is not only will people rip off their finger, which is a dumb practice. Stop doing that, okay? If you do that, you need more IV training. I'm sorry, you need more training. I've done it for 20 years. We've done it for 20 years wrong, okay? It's time to stop doing that. Another thing I've seen online, which is just insane, oh, you're good, buddy, right? Is they'll have a, let's say an IV right here, and then they'll get their IV catheter, and then they'll be like, well, if it's a rolling vein, I know it's a rolling vein. They'll hold their fingers. Maybe I'll visualize it like this, right? They'll hold their fingers like so to keep it in place, and then they'll have their IV out, or the catheter, and then they'll go in like so. And they'll say, this is what really stops a rolling vein. What? What? You know what stops a rolling vein? Applying appropriate pressure, okay? And then hitting it directly. Some people like to hit it to the side in advance. Hit it directly for the vein. This is super inappropriate. You're risking sticking yourself for getting an IV for a patient. If it gets really that bad that they need an IV, either they need ultrasound to establish an IV through the nursing staff, which we're gracious for, or I can set up an IO on a patient. I'm not doing this and risking poking myself in any way if anything happens or if anything messes up with the patient. What are you doing, right? So we boo if we see someone do this. Boo. So I'm going to go ahead and show you guys with this IV catheter more so what it looks like up close and personal. Okay, so one more thing I wanted to visualize with you guys. Whenever we set up an IV, I didn't really mention it earlier, but we want to say bevel up. So you can see right here, we can see the bevel. If we're going into a patient's arm, then we want to keep the bevel up at the same time, okay? The second thing, if you look at this IV catheter here, once it gets into focus, there is a plastic part, which you shouldn't be touching, but I'm showing just for visualization, that stops right before the needle tip, and then you have a needle. And again, you really don't want to do this, but if you see we advance, our needle retracts, and our IV catheter stays into place, okay? So whenever I open up an IV, so we don't recap by putting the cap on, we place it down on a hard surface, excuse me, and then we'll do it like so. If I were to take out this IV catheter, I'm gonna utilize it. I like to break the seal on it, okay? So I'll go left and right, and I'll keep it loose. You don't wanna go up and down with it to break the seal, because then what you can cause is some of the plastic can get trapped inside that bevel there, and then you can put it inside a patient's vein. So we definitely don't wanna do that, okay? So we have it loose, and then we're ready to advance. We'll advance. This one locks, for instance, then a catheter is in. And a lot of times people will have issues again with flash that should appear back here like so. If that's the case, like you get flash but you don't get a good IV, maybe what you need to consider doing is advance. Whenever you first poke your patient with the actual needle still in place, you go just a quarter of an inch further or like a half a centimeter further, and that allows the catheter to get into the vein as well. So a lot of people struggle with that. There are also two other things that you guys need to worry about. So one is whenever two veins come together and they form like a bifurcation, you want to go past the bifurcation. So you can either consider going here or you can consider going here, but watch out for this. Some people like to go straight through it and go into this vein right here. If that's how you're taught, that's fine, but I was always taught to go either before it, so right here would be an ideal one, or you can consider going afterwards. You also can't see it that well, but there is a little bubble right here in my vein personally, right? So there's like a little bubble right here. If that's the case, that is a wall where the vein is kind of like it seals itself off and then opens up periodically. It's allowing the vein to maintain pressure between the different areas for the veins, so it'll lock off certain areas. One's right here. I can't exactly name where the other one's at, but you may be able to visualize it. If not, hopefully I'll have like some imagery to show it to you. You maybe want to start right here and then go into here. If you get it too close to here, or if you're halfway advancing your catheter, right? So this is just a catheter, there's no needle, and we're advancing, and we hit this, then it's going to stop you from advancing any further. Now there's a couple of things you can consider, right? We can either consider taking it off, putting some gauze, some tape over it, and then trying a different area, which is no good. We can also do kind of a Hail Mary play, where basically we will take off everything. We'll pop our tourniquet, right? I'll leave it on just so I can help visualize it a little bit. Let's say for right here, we can take off our tourniquet, take this off, put in a saline flush, and as we're advancing our catheter, we're putting a little bit of pressure with our saline flush, and then hopefully that'll open up the walls, so that way you can barely push this flush through. It's kind of like a Hail Mary. It doesn't really work too well, but it is an option. Hey guys, so I'm going to show an actual live stick where Regis is going to stick me with an IV. He's going to set up however he wants. He got all the stuff here. He wanted to use a J-loop, which is very Regis-like, but he's kind of putting me on it too. And I'm going to let him set up however he wants, and I'm going to show you guys something that I think will be really useful. But Regis has been an FTO in Colorado before he came down here. My shirt's really wrinkled, sorry about that. I just picked out a random one. And as you can see, he's setting up his saline flush right now. You can't really visualize it too well, but he's getting that ready. We'll go over it more later. I'll probably end up putting this at the end of the video if on anything. Okay. So it's going to be kind of out of place, but don't worry about it.
Yeah, no problem.
And he's setting himself up just how he likes. He's going to open up his start kit. Whenever he opens it up, he's going to have things like a tourniquet. What is that called? Is it a Venigard or what is
tachyderm?
It? He's going to have his tachyderm that he can set up. I'm sure I'll clip it later, so it sounds like I know exactly what I'm talking about. You can already see some of my veins kind of popping out. I never use these type of veins, the inner veins. I always go for the outer ones or the AC. I like hand ones a lot, but it's just a personal choice. So while he's setting up, he's going to throw in his tourniquet on me. That way just some blood can build up for a bit.
Alright.
And you can stick me wherever you want.
A little tight.
No problem. So you can see as he puts on this tourniquet, my veins are already starting to pop out a tiny bit more. Oh yeah. This is all genetics, by the way. This isn't for me working out like an insane amount. That's the only reason why they're popping out as they are. But
alright.
He's going to clean up this area. He's going to go for the AC, so he found a good spot right there. What the heck is that, like bacteria? What the fuck? Or whatever.
Yeah.
Alright. Anyway, so he's cleaned up his area. Gave himself some space to work with, and he's going to get his 20 gauge out. And if you can see, he's took out his needle and he twisted it left and right. That way he kind of breaks the seal, but he doesn't go up and down because he doesn't want to accidentally get any plastic in the catheter. So good job on that. All right.
You ready?
Yep.
Okay. Small poke. 1, 2, 3.
Okay. And you want to show them real quick before you do that?
Yeah.
Move anything? You can kind of see, you can't really visualize it, but blood has filled up the chamber. You're good to continue.
Okay.
And he's gotten some flash, and he's advancing, and then leave it right there after you lock it in.
Okay.
So he's locked it into place. Now, a lot of people freak out whenever they lock it into place. You can let go. You can let go. Not a big deal. I'm just going to advance it a tiny bit more. A lot of people freak out whenever they lock it into place. They're like, oh, I need to get my stuff really quick. But look guys. This IV's in me. My arm's moving around. You see how it's not falling out? We can take a moment to kind of breathe in, breathe out a little bit, and set it up. So you can go ahead and set up the saline lock. Oh, just kind of pushing out a tiny bit. Back in there, you. Okay, so he's putting on his pressure how he likes.
It's coming out a little bit.
Yeah, that's all right. Because of all the pressure. And then you want to pop your tourniquet, right? Nice. So you're going to administer some saline. I'm going to get a salty taste in my mouth. Oh, got a little bit of drawback. I'm going to push some saline in. That tastes a little bit of salt. Fantastic. And then he can work on securing it afterwards. He's taking off his flush. And he locked his J-loop because of J-loop, the blood kind of recedes back into it. He's putting his tachyderm in place. He's securing it. And then what some people like to do is they like to get their tape and they like to secure the J-loop. Another 1 to 2 spots. Not a big deal. Fantastic. And as you can see, it's a properly secured IV. Good job, Regis. I'm so glad you didn't miss. Because if you miss, you'd have to do it again, and I think it would have to be another day mentally. But as you can see, can you pass me your gauze pad?
Yes.
You guys see his gauze pad? People only open up their gauze pads whenever they've made a mistake and they've secured it. So you've proved my point. I actually didn't even talk to you about this. Only losers set up their gauze pad while they're setting up an IV because they expect to miss. But Regis had a lot of confidence in his abilities. He didn't set it up because he knows what he's doing. Okay? We don't set this up, right? We'll pull it out and we'll get it ready if we make a mistake. But for the most part, we should be fine. So It's still kind of receding even though it's locked.
Yeah.
It's just all this extra pressure that I have on me. We're going to go ahead and take this out. But okay, thanks.
Yeah.
Here you go.
Dang. Kind of messed it up. Sorry, man.
Oh, you're good.
It's just coming back out.
I don't think it's your fault. I just think I drink an energy drink and the amount of energy that I have is probably too much.
Yeah.
All right. Oh, that felt good.
All right, man. You ready?
This is one thing that we don't practice too often is actually taking out the IV. Oh yeah, get it out, get out of me.
Yeah.
Screw.
Sorry, man.
Don't worry about it. I don't feel any pain.
Cool.
That's interesting, right?
There we go.
Oh, perfect job. I got it.
Thank you.
You can get some tape on it if you want in a moment. The reasons why I don't like students really doing IVs on me when I wanted to make this video was because if I let them do it too much, I look like a pincushion at a certain point, right? I started to look like I was a drug addict or something. So, we got that secured. You did a really good job. Round of applause for Ritas.
Yeah.
Thank you, Ritas. Yeah, let's go. Let's go.
All
right, thanks, buddy.
Yeah, of course.
Hey, see all the sweat piling? Just kidding. All right. Well, guys, I hope you enjoyed the video. If you did, consider liking, commenting, subscribing. I'll put a list of all my different rules that I have for IVs also. That it's kind of jumbled up all over the place, but I still feel like it was pretty comprehensive overall. Maybe there's something that you could grab from this video that you ended up liking. But again, consider liking, commenting, subscribing. It helps the channel out a lot. You can consider joining our Discord. Our Discord. Hello, all of our Discord members. We love all of you. We also consider being a channel member. Oh, those are really cool too. I'm going to show them right now. But with that being said, guys, thank you so much for watching the video. We really appreciate it. And with that being said, I will see you on the next one. Could you imagine if I had like a guitar? See ya.